All right. Hello again, and welcome to another episode of the Down Fracture Podcast, a podcast for talking jaws. Per usual, this is Dr. Michael Wasson of Arizona Jaw Surgery, joined by Dr. Sam Bobek of Seattle Jaw Surgery. Sam, how we doing?
Good man. What's going on? We have a special guest today.
Super special to me, maybe less special to you.
No, I have fond memories of Dr. Hahn. So I'll
Mm.
let you introduce him, but he's joining us from the Midwest, different time zone. He's probably waiting to get home to his family. So I look forward to your intro.
I would disagree. I would say that he's probably more excited to hang out with us. At least I
Absolutely. Right.
Yeah, so we are joined today. Let me do the general housekeeping stuff. Again, downfracturepodcast@gmail.com. We got a few emails again this week. We do like those, good feedback. We do try to respond in a somewhat timely manner. If we don't get to it immediately, we'll try to get back to you. We had some topic suggestions and other things, which is nice. So keep that up. And then, today we are joined by someone very special to me, is Dr. Michael Hahn, who is currently an associate professor and program director at the University of Illinois, Chicago. And Dr. Hahn was 1 year behind me in residency. And to this day, I am of the belief that you were admitted to our program to counteract the negative aspects of me being admitted the year before. Because where I am often referred to by Sam as like a talentless hack and being kind of negative and cynical and
If
maybe even a little bit of a complainer,
if that's
you
the
were the
case, it was
exact
a
opposite.
failure.
What's that?
If that's the case, the project was a failure.
I don't know about that. And you, to most people who know you, are the exact opposite. You were a very happy, pleasant, talented individual. Although I haven't spoken to you in a little while, and I have heard some rumblings that maybe all this power of being a program director has gone to your head. And I don't want to mention any names, but
First source.
Dr. Sapna Lohia and Dr. Lauren Basel said that even as a chief resident, you were starting to get a little what they called swagger, uh, and were a little bit difficult to deal with. And then I also have heard from a few of your former residents that they are not to necessarily address you directly, but if they do have to speak to you, you prefer to go by your Hanness. Is
Oh,
that correct? Is any
right.
of that correct?
I can neither confirm nor deny that.
Well, yes. So we were hoping that you could help us maybe fill in some of the gaps from our previous discussion with Dr. Mark Ingolstadt, who talked to us about some of the challenges of resident education, maybe focusing at least a little bit initially on the admissions process and criteria for OMFS residents, because that has changed significantly since I went through admissions and certainly since Sam did 25 plus years ago.
Easy now. It's not that long. But I mean, that has changed a lot, right? Was it COVID that changed it, or were the
Well,
happenings before then?
I think COVID's part of it. And first of all, thanks for having me. Really nice to catch up with you, Mike and Simon. I kind of feel terrible not having kept in touch as often as I should,
You
but
should.
really a pleasure. I
Yeah.
definitely should. But yeah, so by way of introduction, I'm entering my 10th year in this institution and 6th year as program director. And a lot of what I thought uh, um, went into residency is very different from what it is. As it relates to admission, what programs look for, being in this position for 6 years and talking to other program directors, I think what programs are looking for hasn't changed, right? You have the self-motivated learner, reliable, quick-witted, and intellectually curious. That really hasn't changed, but I think what candidates are looking for has changed significantly. And I think that really changed the dynamic of application and admission. I don't know if you're aware of the match numbers for the past couple of years. Are you familiar with that?
Yeah, we heard about that in terms of some difficulties with matching the different
Right.
programs.
So historically, the unfilled positions have been what in the low single digits, like 5, 4, right? Last year it was 26. This year 21. And there's really an upward trend to this, and it's not really a fluke or a coincidence if it's been going on for 3 to 4 years. And I talked to different program directors, and we all think that it's really a shift in the attitudes toward the specialty.
So
So
can I
yeah.
jump in and ask? Sorry to interrupt, but because I'm not crazy before you guys, but the way oral surgery was in dental school was seen as a competitive specialty,
Mhm.
like there's not, all the different dental specialties have kind of different people they draw from.
Yep.
And so some of the people that were a little bit more interested in obviously hands-on
Mhm.
extractions,
Mhm.
anatomy, high grades, kind of
Mhm.
pushing for academics, those sort of things. Do you see the same group of people coming out of dental school, or do you feel like the specialties changed in relation to maybe like endo or pros or
So
perio?
subjectively, I sense a little bit of a change, like I guess a little less gung ho and a little more casual, so to speak. The can it kind of right, somewhat similar to the other non-surgical specialties, but the numbers are very, very telling. So, do you know? Can you guess the match rate, like the chances of you matching when you apply to oral surgery, just percentage wise, a wild guess?
Um, and this is again my perception of long ago.
Mhm.
I thought the perception was high, that it was high. Like if you
Mhm.
ranked three programs,
Mhm.
and I know people rank more than that,
Mhm.
that I was going to say it's like 90%.
Right, but this is irrespective of whether you get an interview or not. So we're talking about, the 400 plus applicants to oral surgery. Your chances of matching to a residency position.
I'm
I have
still
no
going
clue.
90.
I'm gonna go 60.
For anyone, this could be the person who was like ranked dead last in his or her class, and study the CBSE for 2 days, that type of thing.
Oh, that I mean,
And
I'm gonna
counting like the people who are not even eligible. We were talking about like international grads and people like that.
I feel like you're nudging us downward in our estimate.
Yes.
I'm going to go 20 now. I'll just go
Okay.
at the other end of the spectrum. So unlikely.
Yeah, Mike.
7.
60.
Oh, I was right the first time.
You
Yeah,
were,
you're throwing us off there. I feel
but
like
this is. I'm assuming your guess was based on your chances if you get at least an interview, right?
Right.
yeah, for sure.
So, and if you compare that number to other specialties, specialties historically that have been less competitive, we're actually higher. So at least what the statistics tell us is that we're on paper no longer like the super hard to get into to program.
Huh.
And I really do believe that we collectively as educators haven't really come to terms with that. We're still of the belief that, oh, this is the hard to get into a specialty, and you have to have ace your CBSE, have done like 5-10 research and 5-10 externships. And I think that disconnect is has a lot to do with the fact that we have a lot of open positions.
So the
What
CBSE, what is that?
So that's the so we're of the NBD generation, right? We took the NBD, it was scored, and that was the main. You took NBD, Mike. Okay,
Oh
right.
yeah, yeah,
Yeah,
yeah. Yeah. All
He
right.
just
the
There
did the
was
part
like
one,
same.
a
the
He
part
he
one.
was like in that first percentile that you were talking about
yeah.
in interview still.
So they stopped giving scores for that. I want to say like in 2013 or something like that. Uh,
Okay.
and as a substitute, what they administered was a CBSE, which is basically a practice test for the step one, right? It's administered by the NBME, and then that's been kind of like the uh, um, I guess that you have to ace that. That was our NBDE, right? And the the you know how you remember when you applied, 90 was like the safe score, like above 90 you had a solid chance of matching. That number used to be like 70 as of like 3 4 years ago. That's downtrending quite significantly,
Hmm.
yet we're still having unfilled spots.
So that test is a practice USMLE test,
Yes.
is what you're saying?
Hmm.
And it's not the initial scores when they made the switch from part one or part two on the dental board
Hmm.
to this USMLE test. They were pretty comparable in terms of highly scoring. And what you're saying is over the course of the last 10 years, you've seen it
No, over the course of the
trend
last
down.
3 to 4 years, it's gotten down.
Oh, okay.
Yeah, I think it really peaked maybe right before COVID or right during COVID, but then after that, it's really gone down a lot.
Okay.
Yeah.
So when you're getting applicants from dental schools to your residency, you're looking at that score?
Well, I can't speak for other programs. Well, but what I can say is that pretty much every program uses it as a screening tool because you get like 100 plus, 200 plus applicants. You can't physically look at all the applications, right? Plus, so many schools are pass fail now, so we have to look at something to screen. So at the very least, it's used as a screening tool. Some programs go so far as to use that for like final ranking purposes. And of course, if you have med schools that have a pretty high bar, then med schools kind of demand that you select candidates with a certain score above, because that would kind of it's a predictor for their step one pass, right?
So if they're pass fail, I mean, what else could you use to screen people than that? Like
Right.
that's
No,
really the only
exactly.
tool.
Right. Which is really why it's so hard to it's almost like a I don't know, like a shot in the dark. You know?
Yeah,
Yeah.
that's brutal because, like you said, criteria for our generation was 90% or 90, yeah, 90 or above on your board on your part one dental boards, class rank, and then anything else that you could throw in there,
Mm.
extracurriculars, research,
Right.
letters of recommendation, and all that. But it seems like that's completely gone out the window. And I kind of, I've been involved somewhat with residency programs ever since I got out, but kind of affiliation more than a true
Mm.
position. And so maybe this is semantics, maybe this is just another way of spinning it, but I almost perceive this change from it's gone from where when I was trying to get in, you're scraping, clawing, like you're trying to do whatever you can. It's competitive. And like you as the applicant are desperate to get in.
Hmm.
It almost seems like now it's gone from this as the program, what can you do for me as the applicant, to almost the opposite. The applicants are now like, what can you do for me as a program?
There
And
certainly is that, and sentimentally, like I like many others have this knee-jerk reaction, like, okay, well, that's not how it works, right? But then, if you think about it, it might be a good thing. It means that there are more career options, and it's all about opportunity cost, right? Like residency is a big investment or a sacrifice depending on how you see it. And if the opportunity cost is too high, then you leave. And so I think because there are more opportunities outside, you're familiar with non-specialist or I guess less surgically inclined dentists doing larger cases. These dental graduates are seeing more opportunities that may make the opportunity cost high going into oral surgery. So I think that definitely has a lot to do with the shift in the trainer trainee dynamic.
You,
But like it or not, I just feel like it's something that you have to adapt to. It doesn't matter what I think about it, right?
sure.
What I
Yeah.
won't,
So,
what I where I draw the line though is I'm not going to change the program to cater to those demands. I think every program should have does have a program philosophy, right? And that's something that I think programs should stick with. But as it relates to um, interacting with, I guess, the newer generation of trainees. We just have to accept it and adapt our training methods, not the training
So,
content.
so when you talk to program directors and let's say orthodontics
Mm.
or endo or perio, are they running into the same thing, or is this just like oral surgeries
I
adjusting in relation to them?
I think it's gotten oral surgery seeing like a way higher impact. It is hit much harder because historically oral surgery has been like pretty hierarchical and uh, um, less open. So I do hear some sentiments like that from the other specialists, but not to this degree, not even close.
Sure.
Are you seeing manifestations of this change with the quality of the residents, or do you feel like that's
Uh,
maintaining the quality despite these headaches?
Quality is really hard to. I wouldn't go so far as to weigh in on the quality, but it's just the interactions that are very different. There's
Hmm.
no, um, I guess an easy example is our residency program, our GME, like a lot of GMEs in the nation, have joined a union. So now it's uh, it's really tricky to have residents come in after hours, like for case conference or go past certain hours. We are technically, I guess, violating policies by doing that, right? And if someone's on call during a holiday, they are entitled to an extra day off, that type of thing. So things are very different. But again, I have my knee-jerk reaction to it. But at the end of the day, I can't change it. I have to deal with it. So
Yeah, I mean, there's good and bad things. I mean, I think there's
yeah.
good things about kind of some of the changes with GME and physician wellness and that sort of thing. But on the kind of not enough people going into oral surgery, I kind of find that interesting in terms of kind of, from the medical standpoint versus dental standpoint. Because on the medicine side, my understanding at least is, I could be wrong in this, so correct me, that they have no problems filling residency spots, and it's still kind of as it was before. Is that wrong?
For the
Or
most part, I
in
heard.
medicine, are they running into the same thing?
I think for the most part they're stable.
So like ENT and plastics, when you talk to those program directors, they aren't necessarily seeing a shift in the last 5 years or 7 years of their applicant pool.
Probably not as much as oral surgery.
Okay. Yeah, no, that's all interesting. I mean, it's Wasson, did you know about this? I feel like I'm just catching up to this. So I
No,
appreciate
no, I was aware of this.
it. Okay. And so you think it's just generational, or why do you think? And
Uh,
I mean, if you
yeah.
could like you be suspicious of it, because I mean, honestly, what you're describing, because in dental school, I personally didn't know I wanted to be an oral surgeon until I did my oral surgery rotation.
Mhm.
I just tried to get good grades and learn as much as I could. And the fact that I was interested in it, um, and I had good grades allowed me that pathway. But
Mhm.
I didn't have like some master plan like some people do, or like kind of summer research and all the rest. So I'm kind of interested because you guys had a little bit, you guys were gunning for oral surgery, I think.
Kind of.
I was after my first year. Yeah, it took me my first year to kind of realize it. And then yeah, like I said, it was a battle. Like I don't feel like I was the one dictating things. Like I was trying to get in and not cavalier casual about it. Like, oh, if the circumstances are right, I guess I'll do it. Like
Yeah,
it's
that wasn't my experience at all.
yeah,
But
it was this is what I want to do. What does it take?
right. But to be objective, it's I don't think it's all a generational change. I think you'd agree as a GME funded residency governed by quota, oral surgery got away with a lot of stuff, right? We weren't bound by the 80-hour work a week and things like that. So I think it's a good thing that we're evolving more towards the ACGME model and
Maybe.
having more. But then I guess in a sense, I think there's a little bit of the pendulum being swung the other direction a little too abruptly, right? A little too much and overcompensating. But I'm sure at some point we're going to find an equilibrium.
Well, can you speak to, sorry, Sam,
Oh,
I guess there's the intent or the spirit of a law or a rule, and then there's abuse or misinterpretation. And I'm completely on board with that. At times it's neither safe or advantageous to have people who are overworked and tired or post call doing certain functions.
Mm,
But there's also only so many hours in a day, so many days in a week, so many months, etc.
mm,
And so to like come in for resident education and lectures and things like that, I don't feel like that violates the spirit of the rule. Now, if they're post call and then they have to see a full day of clinic and they might be on call again. So, I mean, I feel like those things and those safeguards have value, but like
yeah.
with what you're describing as a union, like I feel like that's taking away from the resident training, teaching, and experience.
Right. Yes. Yes and no. Well, I think largely so far, I think it's a no. As long as it's not uh, abused or misinterpreted, I think it'll work. I do somewhat agree with you that staying after hours for conferences and didactics is uh, isn't going against the spirit of safety and wellness and things like that. But then again, where do you draw the line, right? Is a cadaver workshop okay? Is a pure didactic okay? Is writing a paper okay? So I do uh,
Direct patient care would be my line, but that's just
right,
my personal opinion, and
but
I'm
yeah.
not in
So
your world.
I'm not opposed to that. And to be fair, I haven't seen um, I haven't had to so far make huge adjustments to our curriculum to adapt to comply with the union and the CBA. But
What if they did it via Zoom like we are?
oh, that would still count as work.
No,
Yeah,
just trying
I
to get
count
clear.
this as work,
yeah.
Wasson. I sorry to get back on the dental student thing, 'cause that sounds interesting to me, because um the generation wouldn't explain the other residencies and the other programs not having those problems, right? Like it sounds interesting in terms of my understanding of the 4 versus 6 year thing was it was more of a 6 year program, but what I'm getting is it's more of an oral surgery in general kind of interest problem. Is that, am I hearing that
I
wrong?
oh you mean like there's a decline in interest to the specialty like in
Yeah,
general,
or
not so
we're,
much.
more like the people we're appealing to are different than what it was
Well,
in the past.
at least number wise, the total number of applicants is about the same. It's in the 400 something, right?
Yeah.
400, 450 range. It's, but so I can't say that the overall interest is going down,
Okay.
but there does seem to be a pretty tangible decrease in interest in the 6 year track. I don't know
Sure.
if you're familiar. Of the
Yep.
21 spots that went upfield, 20 of them were 6 year spots. And
Yep.
it was disproportionately, it was lopsided last year as well. Again, I think it goes back to opportunity costs and what opportunities are, other opportunities are out there for the candidates. My theory is that people are, like in other fields, valuing a work-life balance, and there's, uh, you know, other comparable opportunities out there that would fit their life goals. So I
I
don't
mean, I
think,
guess financially, I mean, there's
yeah,
not
yeah.
many in our profession that allow you to do badass stuff, though. Like you kind of have to do oral
And
surgery for
I
that.
have a feeling that, how I mean, neither of you are this, but the vast majority of graduates go on to, kind of like a office-based, tooth and titanium type of practice, right? Uh, and I think historically, candidates did not believe that that will be them, right? Oh, I'm gonna go to oral surgery. I'm gonna do trauma. I'm gonna do, I'm gonna do like recon and orthognathic and TMJ, and only to go to. So I think nowadays there's a more a better recognition of the fact that if you go to oral surgery program, you'll likely practice office based. So I think that explains partially why there's a perhaps lesser interest in 6 year programs. Uh, and
Where are the people going that got good grades on the the CBSE. I don't even know the acronym, to be
See,
honest.
it is CBSE. They're going to whichever program they like, and that could be a 6-year or 4-year program. But I will say that, and this is just kind of a casual observation, there's a lot of absurdly high scores in the 4-year track as opposed to the other way around.
So the
That
highest
makes
scoring
sense.
people are choosing 4 over
Right.
6.
Right. Well, not.
That makes sense.
Not everyone.
The
but
more
yeah.
the more accurate description would be, as opposed to before, like the really high scores were mostly reserved for the 6-year track. Now it's more evenly distributed. Sometimes you see like really high scores in candidates only applying to 4 years.
At Illinois, do you guys have both tracks, or do you just
We
have?
have both. Yeah.
Okay.
Yeah.
And so you see the mix of that.
Yep. Yep.
Are you guys changing the way you're approaching things because of this 3 to 4 year trend, or are you just going to kind of wait to see
No.
how it goes?
No.
and kinda-
Well, I guess yes. We are less dependent on scores when we're screening now, or rather less selective with scores. We used to have a X cutoff. It used to be 70, but we've adjusted that by lowering it, and we're making sure that we rank enough people, right? Oh, you don't want to be that program that just ranks a handful, right? Just I guess out of pride or tradition or whatever, and only to, because not filling a spot is like a program director's nightmare. That and not having a successful accreditation site visit. Those are the two.
I figured your nightmares involved Wasson in some way, like him dressing or something. But those two things seem more
I missed that.
more reasonable in terms of nightmares.
That's a legit concern.
The certification process, that's the same, right? Like that's every 5 years. That's a pain in the butt.
Right. It's actually, you actually get used to it. Well, I guess I had it. I was eased into it because I had done 2 site visits as a site visitor prior to having my accreditation site visit. And joining a program that's established makes it a little easier because a lot of the groundwork's already done. But it is very, very humbling. Like I thought I had it figured out after having done 2 site visits as a site visitor, but being on the other end, it's like you're like exposing your closet to someone, right? But
You don't want to go in my closet.
Yeah. So I mean, I'm I know it's getting off topic a little bit, but I mean, program directors are like a key function individual in the whole machine of training oral surgery residents. And I always thought it was kind of like there wasn't enough pay bump or extra credit, or like it's what you're doing is so crucial to keep programs moving along. And so I just put a little plug, say thanks for you program directors who might be listening for doing all the thankless work of site visit, paperwork prep, and dealing with all the application stuff. So
but
that's
frankly, it is quite rewarding and fulfilling, as cheesy as it sounds. I mean, I'll be honest, I went into academia with I didn't go in with like altruistic intentions. Honestly, the main reason I decided to go into academia was to be able to practice my scope without having to worry about like extra clinical factors, right? I mean, you two are examples of people practicing, the scope that you want without being in academia. But I went in, but then I this whole teaching and running a program, this all grew on me. And I really do mean it when I say that it's quite rewarding. But there is a trend though towards there's some attrition in academic oral surgery.
yeah, talk about that some more. So in terms of getting enough worker bees who are in the academic path, because and again, I'm not in connection completely here. I just have a general feeling like there's kind of a drift away from having a lot of people who are interested in academics, like at least working for big centers. Is that wrong?
No, there's definitely more that are leaving than are joining, and like some younger academic oral surgeons are leaving academia as well. So I don't know. It's probably multifactorial.
Do you think these two things are a little bit related in terms of the newer generation of people who are kind of going into programs with a different mindset? Do you think they're more or less likely to go into academics?
Or less likely to go into academics. I guess time will tell.
Yeah,
Personally, I've noticed this change in attitude. I'll call it the last 3 to 4 years. So it'll be another 3 to 4 years until we see that group, graduating. But I
got
wouldn't
it.
be surprised if this kind of downtrend of people entering academia continues. Yeah,
So this thing isn't going to help, probably hurt.
at best
Hard to
neutral, I
say.
think.
Okay, yeah. No, I got you.
Yeah.
Yeah, I mean,
Uh,
I want to be optimistic. I just I'm interested in kind of educating. And has there been any legs to medicine pathway? Like
Oh, then
people in
making
medical
it
school
medical
coming
special.
this way?
You mean making this an ACGME a specialty
Oh
or?
no, you know how there's at
Oh,
least a small handful of people who start in medical school and
yeah,
then do a 6-year program that
yeah.
includes 2 years
Like
dental
they
school.
do in Alabama. No, I not as a whole. Some programs do that independently, but there's no because we go to the Amos faculty sessions and there's a bunch of different discussions, but that is not one of the main ones. Yeah,
Got it. So
I don't
that hasn't
foresee
changed
this
too
as
much.
yeah.
it's a mistake.
Yeah.
So Han, you're a smart person. I would
Oh,
also say you're kind of handsome. We give you just full authority here to solve a lot of these issues. Do you have suggestions you're willing to share with us to say, based off of what I see, I feel like if we could make small tweaks, it will make big improvement? Or
so
I heard you say earlier to Sam's question, you think you're not going to make any knee-jerk reactions to a lot of these things, but
uh, yeah.
are there things that can be done maybe outside of the normal thinking that you feel could improve some of these situations?
Yeah, I think the first thing is I think it starts with programs, because you really can't change. If we're attributing part of a phenomenon to generational change, generational attitudes are not it's not a modifiable factor. It doesn't matter what you think, what your opinion is, it's not a modifiable factor. So that's something, in my opinion, you just have to accept. And programs have to accept that first, right? You can't have the same attitude towards admission and expect and expect all the positions to be filled. So I really do think that programs have to accept the change, right? And then the other thing is, what was I gonna say? I had several more in my head and just having a brain fart right now. Um,
Well, while you're thinking about it, because the one that popped in as you're asking the question, Watson, has to do with dental student rotation on oral surgery. You know how I mentioned that's what got me interested actually was doing my actual oral surgery rotation. My understanding at least is that's changed. I mean, at UW that's changed, right? Like it's not an uncommon thing to keep for dental students not to go to the OR anymore. So
You
like
know what? It's
do you
interesting
think
you
that's
say
the
that.
thing?
It's interesting you say that about UW because in Chicago, the same thing happened, but I thought it was just a UIC thing. Um,
Because I mean, if we're not showing dental students how cool it is to hang out with Dr. Han while he's doing a
pulling teeth.
45-minute double jaw, then
Right.
they won't be interested in it, right?
Yeah.
I mean, just do you think there's part of that? Like
You know
maybe
what? Assuming that this is a national trend, then it's probably related to curricular changes to the pre-doctoral dental curriculum, because
sure.
now the structure of the pre-doc dental curriculum now here in this institution, like I can't recognize it. It's like a monster. It's not the classical, different subjects. It's like merged into this big rubric and yada yada. So I think as dental schools evolve their curriculum, relatively speaking, the advanced oral surgery, the full scope oral surgery aspect is diminished, and perhaps that has an impact on um, piquing students' interest too.
Because yeah, I mean, at Oregon, there was kind of like the concern about getting up into the hospital instead of the dental school, right? Like if you're not in the dental school hanging out with the dental students, then it's like the dental students aren't exposed to that sort of thing. Is it?
Mhm.
You think there's maybe some of that too, or
Yeah, yeah, absolutely. Yeah.
um, I don't know.
What
Sorry, I
about
derailed. I was trying to stir your memory a little bit on your other topics.
Well, while you're thinking, let me throw another idea at you. Do
I
you,
remember, I'm gonna write it down because I remembered it now.
oh, I mean, you can go ahead
Feel
if you
like
want.
we're harassing Han too much here.
No, please, no. I have it written down, so I'm not gonna forget.
So, I mean, the other thing I would say is maybe that the whole pass fail of boards, a lot of schools are pass fail now. I mean, I would almost argue that there's some validity to the idea, or at least some correlation to the idea that maybe people just don't know where they stand. And maybe they lack the confidence or, thinking because as I mentioned to you, my personal experience doesn't mirror everyone's, but I wasn't planning, just like you, Sam, I wasn't planning to do oral surgery when I went to dental school. It was kind of like I got there and, everyone tells you how difficult it is and it's supposed to be tough. And here's how you study and all this stuff. And I'm like, man, I just hope I can get by. And, I've always done well, but like this sounds really tough. And then you start getting into it and you're like, okay, I'm doing pretty well at this. Maybe I am cut out for this. And you kind of see where you stand and you fall in line. It gives you some confidence. And maybe that helps spur you towards taking on greater things. And now you don't have a clue because you're all unranked and it's all pass fail and they
Is
give
that
you
how it
hugs
works?
after
Like
every test.
you don't know?
Right. But I do agree with you to a certain extent. But then my argument against that was we've always, as a specialty, we've always had this at least one gold standard quantifiable thing, whether it's an MBD Part 1 with scores or the CBSE. So as it relates to application, and we've always had schools that were pass fail anyway. So and this phenomenon that we're seeing, it's
Do you think that's true though? Like,
5 years.
um, because I mean, I don't remember there being as many schools pass fail in our generation. I'm sure there were some. I remember there were starting to be some when we were kind of getting about it. And then, I mean, I would also say when you place it on one test, I feel like there's just so many differences between the schools in the sense that, one school may get 2 months off to study for things, and one school may get 2 weeks off to
Mhm.
study for things or a holiday break. And like, because some of that stuff is not inherent to dental education. So you're almost going outside of your schooling to learn other extraneous things that you're then tested on with this exam. Is that not
Right.
correct?
But then the applicants have always worked around that. Like even for the NBDE, there are some programs that are very clinical heavy and very superficial in the basic sciences. You always have really high scoring people from those schools. So the people, I think that I guess variations in opportunities have always existed. And I'm not sure how big of a factor that is to the change in the climate. Uh, but back to my like if I had a magic wand and
Yeah,
offer
please.
some, yeah, one is I think programs definitely need to uh, come to terms with the change and accept the change. The other thing is supply and demand. The easy part is uh, well, conceptually easy part is to motivate the students, right? So I think uh, I think you can relate to this, but like one of the punishments, if you will, to oral surgery attendings is to put them in the undergrad pre-doctoral clinic. Like there's the stuff that motivates people to go into surgery, or like any one of us, is the bigger surgeries, right? So there's very low interest to engage with students among I guess full-time academicians, unless your position involves interacting with them a lot. And I think that coupled with the fact that there's less dedicated rotations to post-grad oral surgery dilutes the interest among the candidates. So And this was a big topic in the AMIS faculty sessions. So what can we do to really drum up interest? And that's easier said than done. And even if we were to implement that, that's going to take years. And then there's a supply part, which I think is often ignored. I don't know if you're familiar with the fact that there have been a big increase in the number of open oral surgery positions residency-wise. There are several new programs, and there are existing programs with
like total positions?
yeah. Mhm.
No, what are we up to? Like total positions? Because I imagine this is like 200, but
Right, but it's more. I want to say it's. I can get back to you with the actual number, but
It's
there's at
closer to
least
300.
no, there's not 300, but probably
Closer.
closer to 225 or perhaps 250. Again, don't quote me on that, but there's definitely there's been at least 20 more open spots, right? Whether it's from new programs that's just developed de novo or an existing program that increased enrollment. And if you look at the data from I think 2023 to 2024, there was a sharp increase in the number of unfilled spots. That correlated really closely with the number of increased spots. So now it's a sensitive topic because programs should have autonomy for operational needs to increase the enrollment. But at the same time, you can't increase the enrollment and expect there not to be unfilled spots. So I think that ties into programs' recognition of this. Like they need to come to terms with the fact that you can't have it all, and you have to adapt to the changing times.
yeah, because I would have thought that opening up 20, 25 spots wouldn't be that big of a change, but it must have been just like right at the correct level, like the number of applicants, the number of spots, like they hit some equilibrated happy ground where everyone's just going to fill the spot. So I don't know, it's just a bit of a bummer to hear in terms of coverage at the hospital and coverage at the dental school that there's just less applicants. Oral surgery is such an interesting field. I mean, there's so many different aspects to go into. I mean, the things that we talk about, like jaw surgery and TMJ surgery, are big unmet needs in a ton of communities. Like in many communities, we need more worker bees doing this stuff.
Yeah.
And there's just multiple steps on the process. And if the initial step of dental school and kind of exposure to oral surgery is changing in the negative, it's just a bit of a bummer to hear.
Yeah.
So Sam and I are of the opinion, Sam more strongly than me, that the solution to a lot of this problem is to go to all 4-year programs. Is that kind of your opinion as well?
I would love to hear the
I don't know if that's entirely
rationale
true.
of that. Oh,
The
okay.
intro,
That's a
no,
joke.
no. We have different opinions on this, but I mean, I think changing residency training, do you think that's part of this or no?
You mean like changing the scope?
No. Like in terms of dual pathways or
Oh, kind of like in
uh,
certain parts of Europe.
yeah, other
Like,
countries.
I think it's too late. I mean, certainly that does. I think conceptually that would solve a lot of problems. I think, but I think it would just create a divide. You know,
Yeah, I agree.
like if
Okay,
you,
I think
yeah.
the interesting thing that I took from when Mark Ingolstadt was on here, Han, was that he was of the strong opinion, and I'd love your thoughts on this, that we just need to pick a pathway and all of us be on that pathway because it does create so many unique circumstances for each program that it's hard to unify. It's hard to kind of say, hey, we're all in the same place. Let's all solve the same problem together. He didn't necessarily come out with an opinion of 4 versus 6 strongly, but he was just like, it's hard for us to unify in a number of aspects of educational care because we have one program that has to cater to a medical school and medical admissions, hospital administration, and dictate their program, educational program and calendar around that. while another program has the 4-year program, and then some that have both. And he just felt that a unification on either pathway would go a long way. Do you have thoughts on that?
I think it would be prohibitively difficult to do that. That's my immediate thought. And the other thing,
But
I might
isn't
be
it
shortly.
difficult now? Like, I mean, it's difficult now. So do you think that would be more difficult to unify one way or the other?
I think logistically that's impossible. Right? There's so many moving parts. I think I understand I understand the logic behind it, and I don't necessarily disagree, but I think it doesn't sound very feasible. And the other thing is, I'd like to share with you. I have friends in academic oral surgery in other countries as well. I'm fortunate enough to be active in the International Association. And what I've really come to appreciate a lot in North American oral maxillofacial surgery training is that you have a choice, right? You get to pick and choose which pathway, albeit they're similar-ish, and you can have your reasons. I don't have to agree with uh, the values of a 6-year program, for example, or a hospital-based program, a dental school-based program. It doesn't matter. Like, but you as an adult uh, have your reason, and I think having that choice is beautiful. It's something that I don't think many countries can claim. So I personally think that the value of having the choice outweighs whatever, I guess I'll call inconveniences or minor issues that you may have from
Yeah,
not having a standardized pathway.
I think
Plus,
that's an
it's too late.
interesting.
It's too late.
Yeah, I think that's an interesting perspective too.
Totally.
What do you think, Sam?
No, I mean, I think giving people a choice is great. I think when things change for a few years, it's always like you want to oversteer, but it's this year could be different. When's the New Year cycle start? Like, where are you
July
at?
1st.
When is it?
July 1st.
July 1st. So you have your new residents coming in
Mm-hmm.
like 2 months.
Yep.
Then you got the new crew, and then you start accepting applicants in the fall for applications the
Right.
next cycle.
So the applications start trickling in as early as September, and then generally programs interviewed October, November, and December, and then
So you,
the
so you have
match.
like the month of August just to soak in
Yeah, just
no
on board. And,
applications. You
yeah.
just like vacation and fish and just float
Oh,
around in your
actually,
pool.
August is one of the busier months because you're still onboarding and just acclimating the new group.
So
So
there's just no let up, huh?
no, I mean, no, you get used to it. You get a lot of help.
Yeah, sweet.
Interesting. What
That's
else?
exciting.
What else is going on in the world of academic oral and maxillofacial surgery that dental students or potential applicants may want to know?
Um, well, things happen. Well, I think more and more programs are adapting or embracing the technological changes, and I think you can argue that compared to general dentistry, education in general dentistry, surgical training has been a little bit lagging in adopting digital, planning and things like that to their curricula. I think we're better about that now. I think most programs incorporate at least some aspect of digital dentistry and digital surgical planning. Um, and
You're doing some of your own planning. We were talking about this ahead of time, right? What
Mhm.
what software are you using?
Dolphin 3D for the orthognathic one. Yeah,
Yeah. Are you doing
12
implant planning or no?
Yeah, I do implant planning, co-diagnostics. Mostly, the residents are pretty autonomous with that. But we do one of the things that I I call it an expensive hobby is zygoma implant planning. There's no, in my experience, great software to proprietary software to do zygomatic implant planning. So I use combination of Dolphin 3D,
Yeah.
3D slicer and mesh mixer to not
Dolphins got they
yeah,
have some cylinder thing that you can stick in the
yeah,
cheek,
yeah,
but
and
it's,
then make guides and things like that. But yeah, so that's kind of the scope, and then making some cutting guides and things with things like mesh mixer. That's the, I guess, scope of my in-house planning.
Han, do you think you want one of your kids going into oral surgery?
No, I don't think so.
Why not?
I try not to talk about work, but I think one has potential. She absolutely does not mind the macabre, as you call it, aspect of life. But the other one is, I don't think she's definitely not a surgeon.
Yeah, because I mean, like these education topics, because it's hard not to think about these things when you have kids and as they
Yeah.
progress and all, right? Because I mean, getting them on a path to where they're interested in this sort of thing, it's obviously hard when you're young,
Mm.
but directing them in college and dental school and those sort of things would be great. And easing the path, right? Like having not like a crazy long educational pathway and crazy debt and all the rest of the things that people are fighting these days.
Mm.
It's just, I don't know if I can sweet talk any of my kids into going down the oral surgery path, but I'm of the opinion my daughter's the most likely one currently. Wasson, you have an opinion on your kids?
I mean, I could see either going that route. I mean, my wife's a dentist, and I could see them being interested in getting there. And then I think if you're there, who knows what they'd be interested in?
Yeah.
I think it's possible, but who knows? Well, Han, give me kind of a checklist here because again, I think you've hit on a lot of them, but just maybe summarize this up because again, in our generation and you and I, and then Sam's a few generations behind us, like it was again, board scores, class rank, and then there were the other things you could do to supplement, which would be research, other things. Yeah, I did like
Community
6
outreach.
externships. Are those things still what you guys are looking for?
Yeah.
Are there
Yeah. So
how
what
much do those
programs look
factor
for?
in?
What programs look for have not changed really at all. It's just that what candidates look for have changed and the overall attitude towards applications. So that's really what I mean by the need for programs to embrace that change. You can't.
So research, externships, that's kind of the main things, letters of recommendation.
Oh, another thing that I have not mentioned along those lines is if I think you share the same experience as I do when I say that historically, if you are applying with an internship under your belt, it's a double-edged sword. Some programs loved it, some programs hated it, right? Now I think there is a greater trend towards favoring internship. I always used to tell applicants who are going into internships, like for example, applying for our internship, do not for a second think that just having this internship will give you a huge advantage, because think about the 100+ other people who are doing internships, right? But I think with the change in the atmosphere, there seems to be a pretty palpable change in favor of internships.
Yeah, I definitely think UW did not like that I had done an internship when I arrived.
Yeah, that is an interesting spin. I mean, it makes sense to spend an extra year in education to see if you want to do oral surgery. Wasson, we can see your desktop. I love your looking up old man sayings. You thought you were on the different screen, didn't you?
I was trying to see if I could fit one in for Han. And I was trying to see, because we've used all the ones I think I know. Do you got any old man sayings, Han?
What do you mean, like what? Like words of wisdom, thing like
Sure.
a fortune cookie type of
Yeah,
statement?
sure. Why not? I mean, if you want to make it about Asian culture like you always do.
I don't know. I don't have any wisdom in me.
So, I mean, I was
Yeah.
trying to go to my list and I'm sad that the world got to see that.
Yeah, no, it's great. I mean, I appreciate you joining us today, Han. I think in terms of a lot of the stuff we just kind of have to roll with it. I think your comments on the generational difference is right on. And it's good to hear that you're kind of fighting the good fight to get more residents into the whole training program. So appreciate you joining us.
Yeah, no, and really, and I would like to take this opportunity to thank both of you, because it's not an empty statement when I say that. Like, no one teaches you how to teach, right? And then it's not until you actually are put in this position where you really recognize how how much you've benefited from your mentors and your attending. So Sam and Mike as well. If I'm doing anything positive as a academic oral surgeon program director, definitely there are elements of both of you in me. So I have you to thank for that.
Well,
A lot of
nice
nerve
of you
cutting
to,
and what.
that's nice of you to say. It certainly has nothing to do with me.
Well,
I maybe taught you
multiple
some
things.
shortcuts and how to lie, cheat, and steal a little bit, but you may have gotten some good ones from Sam. But it's still nice of you to say. Oh man. Well, yeah, thanks for coming on again. That was another Down Fracture podcast, a podcast for talking jaws. For anyone who wants to see our faces, there wasn't a lot of visuals on this episode, but we do have a YouTube channel. You can watch the video on Spotify, downfracturepodcast at Gmail for any suggestions, input, feedback. We do read it. We do appreciate it. And again, special thanks to Dr. Michael Hahn of University of Illinois, Chicago for joining us today to talk about resident education and admissions. And see you next time, Sam.
See you later.
Thanks,
Thank
Hahn.
you.
Yeah.
It's a pleasure.